Cushing syndrome is not just weight gain. The key is to recognize a pattern of chronic cortisol excess affecting many systems at the same time. Obesity, diabetes, hypertension, hirsutism, or depression alone are common. They become suspicious when they cluster with more specific signs: thin, bruisable skin, wide purple striae, proximal weakness, or unexplained osteoporosis. Mechanistically, cortisol explains the picture. It raises glucose by increasing gluconeogenesis. It redistributes fat centrally. It breaks down protein, so skin, muscle, and bone become weak. In severe excess, it can act like a mineralocorticoid. High ACTH or POMC-related peptides explain pigmentation. Now look at body fat distribution: rounded face, central obesity, supraclavicular fullness, and dorso-cervical fat pad. The limbs may look relatively thin because muscle is being lost. The skin is often the clue that separates Cushing from simple obesity. Facial plethora, thin, fragile skin, easy bruising, acne, and hirsutism should make you pause. Not every stretch mark is Cushing's. Cushing striae are broad, violaceous, often more than 1 centimeter wide, and occur with thin skin and easy bruising. The muscle clue is very high yield. Ask, can the patient climb stairs? Can they rise from a chair without using their arms? Proximal myopathy is one of the most useful clinical clues. Cortisol also weakens bone. Think of osteopenia, osteoporosis, and vertebral fractures. In children, the warning is weight gain with poor linear growth. Then look for the metabolic footprint: hypertension, glucose intolerance or diabetes, dyslipidemia, and atherosclerotic risk. Alone, they are common, but with catabolic signs, they matter. Severe cortisol excess may overwhelm renal 11-beta HSD2. Then cortisol behaves like aldosterone, causing hypertension, hypokalemia, and edema. This suggests severe disease. Cortisol also suppresses central hormonal axes. Patients may have decreased libido, amenorrhea, and hypogonadism. It may also reduce TSH drive, but that is not the main clinical clue. Do not forget the brain, immune system, and blood. Cushing can cause irritability, emotional lability, anxiety, depression, cognitive problems, and rarely psychosis. It increases infection risk and creates a hypercoagulable state, so DVT and pulmonary embolism are serious complications. Finally, rapid progression, marked hypertension, hypokalemia, edema, and hyperpigmentation over knuckles, scars, or friction areas suggest ACTH-dependent disease, especially ectopic ACTH. The final pearl is simple. Cushing syndrome is pattern recognition: metabolic features plus catabolic clues plus ACTH-related signs.